Thank you very much for your kind introduction, and I'd like to thank the sorry. Uh, okay, I'd like to thank the organizers for their kind invitation. Now, I'm a clinical immunologist working with adult patients, so that will be the topic of my presentation today. I will tell you something about some specific issues that we encounter when dealing with adult patients with inborn errors of immunity. So we already heard that there are 485 genetic defects causing inborn errors of immunity, that these diseases are not as rare as we might have thought earlier. That, of course, depends on the type of genetic defect it is, with some less severe immune deficiency being, of course, more frequent, like IgA immune deficiency or subclass immune deficiency. These diseases usually are diagnosed during childhood because the onset of symptoms is usually during childhood, so pediatricians are the ones that see these patients and diagnose these patients usually. But more than 50% of worldwide incident cases are accounted for by those over the age of 25. When we talk about inborn errors of immunity in adults, the first thing that comes to thought is that these are polygenic diseases, which is not always true. You will see in the next few slides about some monogenic defects causing these diseases with an adult onset as well. And the reasons why these disorders are diagnosed in adulthood basically come down to two main reasons. The first one being diagnostic delay, because there is a lack of awareness of these diseases. And according to a study, there's a mean latency of 16.1 years from, well, actually between the age of onset of symptoms until the genetic diagnosis. Another problem why these disorders occur in adulthood is the delayed onset, which CVID is a typical presentation. It has two peaks of diagnosis in children under the age of 10 and in people in their 20s, between 20 and 30 years. So what are the mechanisms? Why do these inborn errors of immunity have an adult onset? Well, there are hypomorphic variants which actually alter the protein function, but this protein still retains sufficient activity so that the effect is milder and can present later in life. There's also the term of genetic redundancy, which other immune-related genes compensate for the defective protein. We already heard about somatic, which are non-germline variants, and autoantibodies, the cytokines, which cause phenocopies of inborn errors of immunity that typically manifest in adulthood. There are also, of course, environmental factors like vaccinations or infections that might trigger the onset of symptoms in adulthood. There are epigenetic alterations, and we mustn't forget about medical advances like vaccination and prompt use of antibiotics, which during childhood these patients might have been treated more aggressively and more promptly so that they reach adulthood without the diagnosis of an inborn error of immunity. We already heard about the presentation of inborn errors of immunity. In adults, it's basically the same. These are patients that have infections and immune dysregulation symptoms like autoimmunity, autoinflammation, granulomatous inflammation, severe atopy, lymphoproliferation, or malignancy. But there are some specific issues when we talk about diagnosing adult patients with inborn errors of immunity. Usually these patients are seen by many different specialists like ENTs or pulmonologists or infectious disease specialists because of their recurrent infections, usually of the respiratory tract, but also by hematologists because of cytopenias, autoimmune cytopenias, or even lymphomas that are actually might have been caused by an inborn error of immunity. Also gastroenterologists, because these patients sometimes manifest with an inflammatory bowel disease. And sometimes these specialists aren't educated broadly enough and they don't see a pattern that all these manifestations might have a common denominator being an inborn error of immunity. Whereas in children, usually these patients are seen by a primary pediatrician, and pediatricians are a bit more sensitized to think about genetic causes of some diseases. When dealing with adults, we usually don't think about genetic causes in general. Also, another issue is that adult patients usually have a less severe presentation, so that's why they may pass under the radar for a very long time, whereas children, of course, depending on the genetic defect, usually have a more severe presentation. So it's something that alarms medical doctors to think about these diseases. In adults, another problem is that they have a long personal history with some comorbidities that arise from basically age and lifestyle. And sometimes they already receive therapy for autoimmune manifestations, which is immunosuppressive therapy, or even are treated for malignancies, like lymphoma, for example. So sometimes we are led to think that these might be secondary immunodeficiency, which is actually sometimes not true. Whereas in children, well, every child should be healthy, so they should have a short personal history with basically no comorbidities. When you talk about some issues in treating adults, sometimes this diagnostic delay can cause organ damage in adults, whereas in children, of course, depending if the children are treated early enough, there should be less organ damage. As I mentioned before, we also have to think about treatment of their comorbidities, and we are more prone to treat these patients with a less aggressive treatment, since these patients usually have a less severe diagnosis. We already heard about 10 different groups of inborn errors of immunity. I will just mention some of the few monogenic causes of inborn errors of immunity in adults. So the most common inborn error of immunity are antibody deficiency. They account for more than 50% of all inborn errors of immunity. And when we talk about antibody deficiency in adults, we first think about CVID, which is maybe the most common immune deficiency in adults that it requires medical attention. I won't mention a lot of, you can see some genes here that have been found in adult onset CVID, but most patients don't have a genetic diagnosis of CVID. I won't mention these genes because that's the topic of the next presentation. But it's important also to think about some less frequent antibody deficiencies in adults like APDS or BTK deficiency, because in literature there have been patients described with hypomorphic mutations in BTK causing X-linked agammaglobulinemia that actually have some B cells, still functioning B cells that produce immunoglobulins. When we talk about severe combined immune deficiency, we usually think that it's exclusively for children, which is also not the case, because all these 4 mutations have been found in adult onset severe combined immune deficiency, with maybe ADA deficiency being the most heterogeneous of them all. Combined immune deficiency with or without syndromic features can cause a hyper-IgM syndrome or MHC deficiencies, ICOS deficiency, beta-2 microglobulin that manifest as hypoalbuminemia and hypogammaglobulinemia. But I'd also like to mention the George syndrome, chromosome 22 deletion syndrome, which of course doesn't have an onset in adulthood, but many patients can pass under the radar for a very long time. At our center we have a patient that was diagnosed at the age of 42 with the George syndrome because she didn't have some distinctive facial features and she didn't have cardiac malformations, for example, and she was misdiagnosed with epilepsy, which in fact those seizures were basically caused by hypocalcemia, for example. Next, we have dysregulation in inborn errors of immunity. I also won't talk much about them since it's the topic of the next presentation, but you need to know that all these mutations have been described in adult patients as well, and adult onset immune deficiency causing EBV susceptibility diseases or autoimmune lymphoproliferative syndrome, regulatory T cell defects, or hemophagocytic lymphohistiocytosis. Phagocytic disorders are pretty rare, but there have been adults described with GATA2 deficiency and chronic granulomatous disease that actually have somewhat functional protein, so they manifest in adulthood. Innate immune deficiencies can cause recurrent mycobacterial disease or severe virus infections or invasive fungal infections as well. And these are the mutations that have been found in adult onset innate of immunity disorders. Autoinflammatory diseases also can be found in adult onset inborn errors of immunity, maybe the familiar periodic fever or TRAPS syndrome being the most frequent one, but you can see that there are a lot of other actually genetic mutations found in adult onset autoinflammatory disorders. Complement deficiencies are also pretty rare, but it's important to think that they might cause autoimmune, a typical hemolytic uremic syndrome, that these are patients that might have meningococcal disease. But for example, for rheumatologists maybe in the audience, it's also important to think about patients that have lupus, and they might have actually a complement deficiency, especially in patients whose lupus is not active, but they keep having low complement levels. So basically it might be a complement immune deficiency causing lupus. And lastly, we have phencopies of immune deficiencies, which can be associated with somatic mutations or with autoantibodies. I will just mention that we've learned that people with autoantibodies to type 1 interferons have more severe COVID-19, for example, but you can see that all these other cytokines can be affected in a way that these people produce antibodies to these cytokines. In this picture, you can see the oldest age of onset in patients reported with all these diseases. And you can see maybe in the group of autoinflammatory diseases and diseases of immune dysregulation that these patients can be diagnosed even after the age of 80. So it's something that is important to think about. The more severe presentations like immunodeficiency affecting cellular and humoral immunity are of course diagnosed a bit earlier. So basically, in conclusion, I just wanted to mention that inborn errors of immunity in adults are more than just antibody deficiency, especially CVID, which is maybe the first immune deficiency that we think about when we talk about adults. They usually do have a less severe presentation than in children, but also there are some manifestations that can be life-threatening. And it's important, and we need to raise awareness among other specialties to think about these diseases in patients that have recurrent infections or recurrent fevers or severe infections, as well as some autoimmune manifestations, that all these different manifestations might have a common denominator being an inborn error of immunity. So thank you for your attention.